Good morning, everyone. Over the next 30 minutes, I will be discussing regarding why there is need for hepatitis B screening before a patient scheduled for chemotherapy or immunosuppressive therapy, how to screen this patient and assess the risk for hepatitis B reactivation, what are the mechanisms of hepatitis B related liver injury after chemotherapy or immunotherapy, and what should be the management approach, whether it should be prophylaxis or monitor the hepatitis B DNA. And in the end, I will discuss some special scenarios and the conclusion. So this is a sort of disclaimer that all patients scheduled for immunosuppressive therapy or chemotherapy having any sort of hepatitis B infection, whether it is chronic, inactive, active, past or resolved hepatitis B infection, are at a varying risk for hepatitis B reactivation. So none of the therapy is safe, and we should be actively searching for hepatitis B reactivation, and it is up to the physician to decide and quantify the risk of reactivation and to make the informed decisions. So before moving forward, let us take some 3 common scenarios. A patient with 57-year-old female presented with jaundice, diagnosed to have acute severe autoimmune hepatitis, and she was planned for high dose steroids for 4 weeks, then low dose steroids for more than 2 years depending on the response. Second case is a 48-year-old male who is having the metabolic syndrome with alcohol use disorder, incidentally detected to have SCC, not willing for surgery, and was planned for TACE followed by immunotherapy. And third case is a young patient with drug abuser who is hepatitis B and C co-infection with active SCV infection and planned for DAs for hepatitis C infection. So the common issues in these patients is what is the risk of hepatitis B reactivation in these cases, and do we all these 3 patients need the hepatitis B targeted therapies or need monitoring. I will come to these slides later on in the end of the presentation. So any abrupt increase in the hepatitis B replication in a patient with chronic or past hepatitis B infection is called the reactivation of hepatitis B. And depending on the whether it is the active infection with the chronic hepatitis B infection, the rise in DNA based on the various thresholds, it is called reactivation. And in patients with the past infection with the S antigen negative, the reverse seroconversion, which is defined by the reappearance of the HBsAg negative to positive, or the appearance of DNA, is called the reactivation as per the newer guidelines. What is the importance of recognizing reactivation of hepatitis B in a patient on immunotherapy or the chemotherapy? Because it increases the risk of liver injury post flares. It increases the risk of ACLF in patients, some of the patients, particularly in those patients who have underlying liver cirrhosis, which may be potentially fatal. It leads to interruption in the scheduled chemotherapy or the immunosuppressive therapy, which may lead to delay in the treatment of the underlying disease, and overall it may lead to the increased cost of the treatment because of the potential risk of hospitalization and the liver failure. So the studies globally have shown that the most common cause of hepatitis B reactivation worldwide is related to the use of immunosuppressive therapy, whether it is due to the cancer chemotherapy, anti-rejection drugs post-transplantation, or the increasing use of the monoclonal antibodies, the cytokine inhibitors, or the corticosteroids in patients with various indications, whether it is in the rheumatology, in the dermatology, or in patients with metabolic diseases, or even in the infection where the monoclonal antibodies have been used. So this is the figure showing the incidence of hepatitis B reactivation after the chemotherapy. The studies have shown that the patients who is having the HBsAg positive lymphoma and on treatment with R-CHOP based regimen containing rituximab, there is a very high risk of reactivation. You can see in this cartoon, it is almost more than 50% in patients with lymphoma on rituximab based chemotherapy. However, even in patients with resolved HBV infection, which is defined as the S antigen negative, anti-HBC positive, the risk of reactivation with R-CHOP regimen is around 18% and the 17%. The patient with breast cancer treated with doxorubicin, the risk of reactivation is around 29%, and patient with SCC planned for TACE and who is having the baseline HBV DNA positive, the risk of reactivation is as high as 40%. So the timing and the onset of the HBV reactivation after the chemotherapy or the immunosuppressive therapy depends on the disease underlying disease status, the host immune response, as well as the intensity and the type of immunosuppressive therapy. It may vary with the very potent immunotherapy. It may occur within 2 weeks of the start of immunotherapy, but in patients with very low potent immunotherapy, it may occur very late also. So what happens is initially there is asymptomatic rise in the HBV DNA, which is called the reactivation after the start of the chemotherapy. Then in some of these patients, after the reactivation, there is a hepatitis B flare, which is characterized by the ALT increase by more than 3 to 5 fold. In some of the patients with ALT flare or hepatitis B flare, then there is a progression to jaundice, development of liver failure, coagulopathy, ascites, and development of ACLF. And most of the patients, there is either spontaneously or the timely initiation of the antiviral therapy, there is a improvement in this the reactivation, and the patient has the DNA decline and the patient improves. And this is the systemic review of the 14 studies which have taken the patient with HBsAg positive lymphoma patients on systemic chemotherapy. They have shown that the risk of reactivation is around 38%, the risk of hepatitis is 33%, and risk of liver failure is around 13%, with high mortality around 5.5%. So this is regarding this why we need the screening for hepatitis B in patients who is planned for immunotherapy or the chemotherapy. So before going further, how to screen and how to assess the risk of the hepatitis B reactivation, let us take up a case. A 50-year-old female who is a known case of CA breast, and she was treated with doxorubicin and cyclophosphamide. And initial baseline ALT before the start of the chemotherapy was 23, and while undergoing the chemotherapy, the ALT rose to from 53 to 153. So as obvious, the initial diagnosis was drug-induced liver injury. She has no features of liver failure. INR was normal. There's no jaundice, no normal mentation, and patient was advised to visit the OPD after 1 week with labs. Then after 7 days on follow-up, his HBsAg was positive, which was not detected before, which was not screened before, and she had a mild jaundice and coagulopathy, and she was admitted for further workup. And within a day, the patient become confused. There is high INR, there is appearance of jaundice despite the start of tenofovir 1 day prior. And she was admitted to ICU and she died because of multi-organ failure. The DNA report came out to be more than 7 log. So this was the case of chemotherapy related severe reactivation of hepatitis B. The transplant was contraindicated because of the active CA breast, and there was no improvement with tenofovir. And this is the importance of screening for hepatitis B infection in a patient with high intensity chemotherapy, and HBsAg testing and prophylactic antiviral before the chemotherapy could have prevented this preventable death. So what are the risk factors for hepatitis B reactivation on chemotherapy or immunosuppressive therapy? There are host factors. It is more common in patients who are elderly male, patient with underlying cirrhosis, and some hematological malignancies including lymphoma has the higher risk of reactivation. Some chemotherapy or immunosuppressive therapy are more notorious to develop to cause reactivation, like the rituximab, the conditioning therapy for bone marrow transplant or stem cell transplantation, high dose of steroids or anthracycline based chemotherapy. And there are viral factors. Patient with active viral infections like the HBsAg positive with high DNA has more risk of reactivation as compared to patients who are having the resolved HBV infection. And the guidelines have suggested that the more than 10% risk is considered as a high risk of reactivation, and this is associated with the patients who are on the anti-CD20 monoclonal antibodies like rituximab, high dose steroids which have been defined in the studies as more than 20 milligram per day for more than 4 weeks, anti-TNF agents like the adalimumab and the infliximab, anthracycline based chemotherapy like doxorubicin and the epirubicin, the hematopoietic stem cell transplant, more in the allogenic transplant than the autologous transplantation, the immune checkpoint inhibitors with high dose, prolonged duration, and the certain tyrosine kinase inhibitors. Moreover, even in the patient with resolved HBV infection characterized by the core positive surface antigen negative, the high risk of reactivation still is there with the use of rituximab and post bone marrow transplantation. The moderate risk of reactivation in patients include the cytotoxic systemic chemotherapy except the anthracycline, the anti-TNF agents with lower potency like the etanercept, the medium dose of the steroids and the proteasome inhibitors, and the low risk is with the use of the low dose of steroids, the methotrexate, azathioprine, etc. So when a patient come to our clinic with potentially start of the immunotherapy or chemotherapy agents, how to assess the risk? So we need to see the potency of the immunosuppressive agent which we are planning to give in this patient. Then we see we screen for the hepatitis B screening. The screening should be of hepatitis B should be done by the HBsAg, the core antibodies and anti-HBs in patient with HBsAg negative. And if the HBsAg is positive, then HBV DNA should be done. This is to determine the status of the hepatitis B. If the HBsAg is negative, core antibody is positive, then it is called the resolved HBV infection. And if the patient is having the HBsAg negative but DNA is positive, then it may be occult HBV infection. Or if the DNA is positive and HBsAg is positive, then it is most likely the immune active chronic hepatitis B. So if a patient is given the low potent immunosuppressive therapy like the methotrexate, azathioprine, low dose of steroids, and patient is having the resolved HBV infection, then there is a very low risk of reactivation, 0 to 1%. There is high immune control, risk of reactivation is low. However, if the same immunotherapy is used in patient with immune active hepatitis B, then the risk of reactivation increases to the 1 to 10%. Similarly, in patients with highly potent immunotherapy with active HBV infection with high DNA, especially in high DNA HBsAg positive, the risk of reactivation is high. And when the same immunotherapy is given in a patient with resolved HBV infection, the risk decreases substantially. Now, it is not always that the risk of reactivation is high only with the high potent immunotherapy agent. Even in patients, when we start the medium potent immunotherapy agent like the infliximab at start, and we add on the steroid in this patient, which is also a moderate dose steroids, then the risk increases. The combination of the moderate intensity immunosuppression lead to high risk of reactivation, especially in a patient with HBsAg positive chronic hepatitis B. And studies have shown that even in the patient with resolved HBV infection, the high anti-HBs titers have shown to prevent the risk of reactivation, especially in patients who are planned for rituximab-based chemotherapy. So anti-HBs titer should be done in patient with core positive S antigen negative patients with high potent immunosuppression, because if anti-HBs titer is more than 100, then the risk of reactivation is substantially low. Moreover, in patient with resolved HBV infection, the HBsAg is negative. So some of the patients may be harboring the pre-core mutants. So when we give the rituximab-based therapy, which is a potent immunosuppression, in the presence of the pre-core mutant, there is a very rapid rise in the HBV DNA. And when we use the high ultrasensitive HBsAg assay before the start of rituximab therapy, then it may early detection of the HBsAg positive and timely start of the prophylactic nucleoside analogs may prevent the reactivation in such cases. Although the screening for hepatitis B infection before the chemotherapy is cost effective in multiple studies, but there is suboptimal screening and treatment. The studies from the survey from the ASLD members for reactivation experience during cancer chemotherapy have shown that the physicians only use hepatitis B screening before chemotherapy in almost 50% of the cases, and this is more common among the oncologists, rheumatologists, and dermatologists as compared to the gastroenterologists and hepatologists who are more aware of the hepatitis B reactivation. The screening is generally 30 to 70% in various series. So now coming to what is the mechanism of hepatitis B related liver injury after chemotherapy or immunosuppressive therapy. The hepatitis B reactivation is a function of increased hepatitis B replication and the decreased host immune response. So, whatever therapies which are currently available are at most helpful in achieving the functional cure, which is defined by the HBsAg laws. But still, the immune response is not potent enough to eradicate all the niche of infected cells harboring the CCC DNA, integrated HPV DNA, or the lower level of replicating DNA that escape the targeting by the hepatitis B immune cells. So, inside the nucleus of the hepatocytes, there is a when the virus nucleocapsid burst and the genome goes inside the nucleus, then there is a repair by polymerase and formation of CCC DNA, which is quite stable, and it binds with the histones and the histone-related protein to form mini chromosomes, which is very stable otherwise, and it persists for years without any in a stable state. In a presence of the immunosuppression, there is a epigenetic loss of epigenetic control and lead to the increased replication of the virus. There is increased transcription and leading to the hepatitis B replication. So, as you can see in this cartoon, the hepatitis B replication is prevented by the body immune response by either by the T cells response, which may be through CD4 positive cells, CD8 positive cells, by cytotoxic response, or the non-cytotoxic response by interferon, or the B cell response by production of the neutralizing antibodies which bind to the hepatitis B and surface. And the innate immune response is also important to control the hepatitis B replication. So, when we start the immunotherapy or immunosuppressive agents or the chemotherapeutic agents, you can see here the histone deacetylator inhibitors, which hampers the epigenetic control and it leads to increased viral replication. The kinase inhibitors or TNF alpha inhibitors affect the innate response and increase the signaling, leading to hepatitis B reactivation. Then the corticosteroids use have been shown to block the functions of the T cells as well as B cells, which lead to reactivation. The B cell depleting agents like the rituximab target the B cells, which lead to decreased production of the neutralizing antibodies. So, all this lead to hamper the immune function and lead to the viral replication. So, what happens after the reactivation or the increased viral replication? So, whenever there is an increased viral replication in the absence of the dominant adaptive immune response, there is a activation of the innate immune response. There is production of the interferon alpha by the plasmacytoid dendritic cell, increase NK cell activation, inflammatory phenotype, which will lead to the cytotoxic hepatitis B cells killing, leading to and the activation of the macrophages, Kupffer cells, leading to production of the cytokines, and then this lead to the cell lysis, production of the leading to hepatitis B flare, active hepatitis, and risk of further ACLF. Then this is the hepatitis B surface antigen. You can see that then from the 0.99 to 199 in the surface protein gene. So, there is a major hydrophilic region which is the region where the anti-HBs binds. So, if there is mutation in this region, so these are the mutations. These are studies which have shown that the 8 mutations are there in this region, and this due to this mutation the antibodies cannot bind and the virus replicate quickly, and the mutations in the hepatitis B surface may lead to the escape mutations lead to the hepatitis B reactivation due to increased viral replication. So, how to manage the patients who is planned for immunosuppression chemotherapy once we assess the risk of hepatitis B reactivation? So, multiple studies have shown that the prophylactic antiviral therapy before the initiation of the or at the time of initiation of the chemotherapeutic agents is helpful, and it is more effective than the therapeutic antiviral, which is started at the first sign of hepatitis B reactivation in terms of decreased risk of hepatitis B flares, decreased risk of hepatitis, and the liver failure. All treatment eligible patient chronic hepatitis B who is planned for immunotherapy or chemotherapy should be given prophylactic antiviral agents, like the patients who have cirrhosis, patients with high DNA, high ALT, or patient with advanced fibrosis with more than F2 fibrosis, or ALT is high or DNA is high. Then in these patients, these patients are treatment worthy, and these patients should be given antiviral therapy without any further thought. And which antiviral to be used? The studies have shown that this is the study which have used the entecavir compared to lamivudine, and in hepatitis B surface antigen positive patient using receiving the rituximab based chemotherapy. This study have shown that the entecavir is much more helpful as compared to lamivudine, and it prevents the hepatitis B reactivation. And the comparison of tenofovir versus entecavir have shown that the similar efficacy in both the cases. The reactivation rate is 10% and 14%, which is not significant. And once we decide the type of antiviral therapy, what it should be the duration of antiviral therapy in patient, the studies have shown that the once we give the immunosuppression, we should give at least 6 months after the stoppage of the immunosuppressive agent. However, in case of the highly potent immunosuppressive agents like rituximab or the post bone marrow transplant, then the therapy should be given for at least 12 months or lifelong. So, the antiviral prophylaxis should be started before or simultaneously to the immunosuppressive therapy, or at least 1 week before immunosuppressive therapy in patient with baseline HBV DNA more than 4 log. Now, coming back to our 3 scenarios which we had discussed earlier. First was the patient with acute severe hepatitis who is planned for the steroid based therapy. The studies have shown the high risk of HBV reactivation after the corticosteroid therapy in a patient, even in patients who have the resolved HBV infection. Mainly, the risk increases with the duration, with the dose of the corticosteroids. So, this study have shown that if we use the 40 milligram of prednisolone, then the risk of reactivation is around 10 to 15%. And more the duration of the antiviral therapy, more the duration of the steroid use. If we give the moderate duration of steroid for more than 4 weeks, then it also increases the risk of reactivation. And there have been some reported of fatal cases of hepatitis B reactivation during the long-term low-dose steroid therapy in patients with an inactive hepatitis B carrier. Then second case is a patient with SCC planned for TACE and immunotherapy who is surface antigen negative, core antibody positive. This is the latest systemic review of hepatitis B reactivation during the therapies for SCC. This study was published in Hepatology, including the Asian patients where the high risk of reactivation was seen after resection, after TACE, and after radiation for SCC, intermediate risk for ablation and the systemic therapy. And the use of the immune checkpoint inhibitors in cancer patients lead to very low risk of hepatitis B reactivation, almost negligible risk of hepatitis B reactivation in those patients who have the HBsAg negative, anti-core positive. And use of the prophylactic antiviral therapy should be done in patients with HBsAg positive because it prevents the risk of reactivation. Then the third scenario was the patient with co-infection with hepatitis B and C, and then he is having the active HCV infection. As we know that the hepatitis B and C tend to interfere with their replication. In most of the cases, the hepatitis C is more active, and it decreases the replication of the hepatitis B and lead to the HBV DNA is negative. But when we start the antiviral therapy for hepatitis C, then the hepatitis with the decrease in the HCV RNA, then there is high risk of reactivation of the hepatitis B. And the studies have shown that the pooled risk of reactivation of hepatitis B after the HCV therapy, for especially on DAS, is around 24%, and some of the patients may have the risk of ACLF, especially in patients who have cirrhosis. So, in our case where the HBsAg was positive, the DNA was low, then there are 2 scenarios: either to give prophylactic antivirals until the 12 weeks after the DAS completion, or the monitor carefully with HBV DNA every 15 days and LFT. If there is early signs of reactivation, early signs of HBV DNA increase, then we start the antiviral therapy. Then this is my conclusion slide. So, all patients who are planned for immunosuppressive therapy should be screened. How to screen? By HBsAg, anti-HBc, and the anti-HBs. For HBsAg positive, we should do the quantitative anti-HBsAg, DNA testing, and the LFT should be considered. And we assess the fibrosis of this patient by using the liver stiffness measurement or the non-invasive measurement in patients who have underlying significant fibrosis, advanced fibrosis, or patient having cirrhosis. Irrespective of the risk of reactivation, we should give the prophylactic antiviral therapy. In patient who is anti-HBC positive, negative, or and the surface antibodies are negative, then should provide the vaccination. And the risk of reactivation should be assessed only in patients who are treatment ineligible, because all eligible patients we should give the prophylactic antivirals. If there is high potent antivirals we are using, then nucleoside prophylaxis should be given preferably with tenofovir or entecavir for at least 12 months or beyond. In patient with moderate intensity, moderate risk of reactivation, if HBsAg is positive, then nucleoside analog for 6 months. If negative, HBsAg is negative, resolved HBV infection, no advanced fibrosis, then should monitor for every 3 monthly with DNA and ALT. In patient with low risk of reactivation, then if it is advanced fibrosis, then we should give prophylactic antivirals. If there is no advanced fibrosis, then we should monitor every 3 monthly with ALT and the DNA. And then we should carefully monitor these patients. Thank you for the kind attention.